Good day and welcome to week 5 and module 5. We're going to be looking at EHR and telemedicine. So let's first look at the history of electronic health records. In the 1960s, a man by the name of Dr. Lawrence Reed introduced the problem-oriented medical record, also known as the POMR. There were 5 components of the POMR listed here as the database, the complete problem list, the initial planning, daily progress notes, as well as the discharge summary. So the database was the foundation for all of the information, as well as the complete medical history. The importance of the database is obvious and must include that complete history and physical exam of each patient. Looking at the complete problem list, we had to, as clinicians, we had to inform or have complete history, as much information as possible of the patient. The initial planning process, after the physician would gauge each issue of the patient, that is where they needed to decide what to do and how to create a plan of action. The daily progress note was pretty much a narrative of what was going to happen with each patient. And then your discharge summary was the final progress note. The final progress note included any active problems. It was defined what needed to be done with each patient as they were discharged from the hospital. And then in 1972, the Regent Street Institute in Indianapolis had been developed the portable medical records. So the VA was the first major organization to implement an electronic health record system. In the 1980s, more smaller facilities and private practices began to use EHR, and then in the 1990s, more academic inpatient and outpatient facilities began to use EHR for data interchange, claims processing, and image scanning. Some of the benefits of EHR, of course, are listed here. It does help improve patient care. It increases patient participation. It improves care coordination between those physicians, especially their PCPs and any specialists that they might be seeing. It improves diagnostics and patient outcomes, as well as practice efficiencies and cost saving. With benefits, there's always some disadvantages as well. We deal with privacy and cybersecurity issues. Some inaccurate data may be input into the EHR system. There's some malpractice liability concerns, as well as it does cost a lot of money and it is time consuming to implement an EHR system, and some people see it as an inconvenience and inefficiency. There are many key components to EHR listed here as you can see the clinical decision support, which we'll talk about, computerized physician order entries, electronic encounter notes, referral management, patient reminders, which are very helpful, public health reporting, which has been also high on that component side, electronic prescribing, and registry. Computerized physician order entry. What CPOE is the process of providers entering and sending any treatment instructions for patients. So that could be, again, in the form of medications, any lab orders, or any x-rays, CT scans, anything in radiology that needs to be ordered for a patient. It is very important for these CPOEs to be entered because it helps reduce errors and also improves patient safety. It improves efficiency by electronic ordering because as any order that is signed, sometimes it is difficult to read the doctor's signature or also read what is being ordered, so it improves that efficiency, and then also improves reimbursements. The next component is CDSS, or Clinical Decision Support Systems. And CDSS is Health Information Technology, helps provide clinicians, staff, patients, and other individuals with knowledge and person-specific information to help health and healthcare. They are computer-based programs, and they help analyze data within the EHR systems. What CDSS is, it provides prompts and reminders. So when you log into an EHR system and you access a patient's chart, and let's say they are allergic to penicillin, that alert is part of a clinical decision support system. So it can be any software that assists decisions in a CDSS. So that knowledge support, those programs that are embedded into the EHR that educate clinicians or patients, the calculators that are used in EHR that is part of CDSS, any flowcharts and graphs, those reminders that remind clinicians or patients about any pending tests or anything that needs to be upcoming if a patient is due for colonoscopy. Those reminders that let clinicians know, hey, you are due for a mammogram or you are due for colonoscopy this year. And then any of those public health alerts, that's all part of the CDSS. And then we come to electronic prescribing. Electronic prescribing or e-prescribing is the computer-based electronic generation, transmission, and filling of a medical prescription, taking the place of paper and faxed prescriptions. And there are benefits and challenges, of course, to e-prescribing. The benefits are the legible and complete prescriptions, just like as in the ordering the CPOE for any labs or testing like that. We don't have to worry about not being able to read the prescriptions. The wait to pick up prescriptions are a lot shorter because they can be faxed in or they can be called in, which that decreases the wait time. Another benefit is the timely notification of drug alerts and updates. And the process is secure and it's also HIPAA compliant. And now there are some challenges as well. Alert fatigue, and there's also some prescription errors. Sometimes there are some medications that may look similar, and so when ordering a prescription, the person ordering the prescription may accidentally order the wrong thing because they look similar in nature. Some more EHR challenges, which we've talked about a few, but some other ones, the financial responsibility. The upfront cost is going to be steep, but in the long run, it does even out. The physician resistance. A lot of doctors are resistant to learn an EHR system. They are set in their ways and they do not want to learn new technology. Loss of productivity. Training staff on EHR systems, that takes a lot of time. And so there's a lot of downtime in productivity. Privacy concerns. And then the lack of interoperability. EHR systems not being able to communicate with other hospitals. So those are some concerns when implementing EHRs. So we had discussed, or I had mentioned meaningful use in the past, so let's talk about it a little bit more. So meaningful use has been implemented to help incentivize physicians and hospitals for using a certified EHR system. And meaningful use helps to improve the quality, safety, and efficiency. It reduces health disparities. It helps to improve that care coordination between those physicians to help improve patient outcomes. It improves the population and public health. It helps to engage patients and their families in their own health care, and also ensures that patient privacy and security is maintained. And there are three basic components to meaningful use. One, there has to be a use of a certified EHR, the electronic exchange of health information to improve the quality of the care, and then the use of the certified EHR technology is to be submitted clinical quality and other measures. And these EHR incentive programs are through Medicare and Medicaid. They have the incentive payments from using the EHR. Hospitals and clinicians do receive those incentive payments throughout the years, depending on when they started using it, and then they receive incentive payments each year after. You do have to be an eligible professional or an eligible hospital to receive those incentive payments. And this is just an example of meaningful use. There are three different stages. Stage 1, it shows you the meaningful use criteria, what they focus on. Stage 2 and Stage 3, and this is just an example. There are a lot of other examples that I could show you, but I just wanted to show you this basic example of each stage. And discussing the eligible professionals. For Medicare, The eligible professionals are listed here. They must be a doctor of medicine or osteopathy, doctors of dental surgery or medicine, podiatrists, optometrists, or chiropractors. Medicaid eligible professionals must be physicians, nurse practitioners, certified nurse midwives, dentists, or physician assistants. And then this is just, we talked about the size of EHR systems. This isn't a one size fits all. There are different EHR systems based on the size of your hospital or the size of your doctor's office. So for a small primary practice or a small hospital, Amazing Charts is one type of EHR. And this is just your basic screen. This is one of the basic screens for Amazing Charts. Very simple. It's very straight to the point. There are not a lot of tabs that need to be open, but it has your schedule, which you can see with the dates and the patients and what time they're in there. So it's just your very basic EHR stuff. For a medium-sized hospital, eClinicalWorks is for more clinician and patient features, mobile and health information exchange. It's a little bit more invasive and has more interoperability examples. You can add different doctors, different panels on here. You can do a lot more with the eClinicalWorks. And as you can see here over on the left hand side, these are all the different doctors that you can choose from. So depending on which patient each doctor sees, you can click on the doctor and then see which patient is being seen by that doctor as you need to. And then for large hospitals such as ProMedica, they use Epic, but it does include every aspect of meaningful use. So it's nice that it's built right in. And then especially for ProMedica, they have different satellite offices, so they're all able to interconnect. So the interoperability is in there. And this is just an example of what a screen looks like for Epic. And for Epic, you actually have a training session. And as you can see, there are a lot more tabs that are involved in Epic. So this is just a timeline of an ER implementation. It does take sometimes a year to 2 years, sometimes even longer depending on the size of your facility. So I've been with two hospitals that have gone live with the EHR system, and it's always been longer than what they've anticipated. So it is definitely a very long process to implement that system. All right, now let's move on to telemedicine. Telemedicine is sometimes interchangeable with telehealth, however they are different. Telemedicine is the use of electronic information and communication technologies to provide and support healthcare when distance separates the participants, which we use telehealth quite a bit. There are 3 types of telemedicine. We've got real-time communication, store and forward, and then remote patient monitoring. Telemedicine allows physicians to treat patients virtually.